instrumentation. For those of you who have not seen the femtosecond laser and its use for keratoplasty, this is a patient of mine who had previous hexagonal keratotomy, an older treatment for hyperopia. We see here this is the zigzag edge profile, so it starts with a posterior side cut, starts posteriorly, then moves anteriorly, ring lamellar cut, and then this anterior side cut. And you see where the air bubble now is broken through, cutting into the glass, and then the creation of these radial alignment marks. You can make anywhere from 4 to 12 of those to help with tissue distribution. One thing I find very helpful is when I use the femtosecond laser, it will cut down to a very deep depth. I know exactly how deep it's cutting. So when I go in with my focal instruments, no financial interest, unlike Rajesh, I'm always very deep stroma. So my success as far as getting a big bubble is much higher when I use a femtosecond laser than when I perform a manual trephination. You'll see that I've reinforced these marks with ink because they do tend to fade. But the eye bank is cutting the donor. I'm the one who cuts the recipient. And the donor cornea also has these alignment marks. So you can ensure perfect distribution of the tissue when using the femtosecond laser, either for a DAOK or penetrating keratoplasty. Also, there's this posterior side cut that's at an angle. It's a 30-degree angle, so I don't have to hold my scissors perpendicular to the decimates in order to cut. I can cut along that angle, which for me makes it a little bit safer. One of the nice advantages also of the femtosecond laser, look at that perfect matching of the donor and host surfaces. Because you have this zigzag edge profile, you get this interdigitation of the donor and the host, so you really don't see, so you really don't see the step that you can see many times in a traditional DAOK performed with a manual trephination technique. Here's that patient whose video we saw. This is about a month after surgery. You know that with a DAOK, there's rapid detrajections of the donor cornea. I'll draw your attention here to the wound. You can see the zig and zag right there interdigitating very well. And I have never seen to date, knock on wood, a malalignment of the donor and the host. When I've used that zigzag profile, always the donor and the host meet as they should. The same patient topography, here looking at 3 months. Not all of them have less than a diopter, but of course I'll show you the one that does have less than a diopter if astigmatism was also presented. So to date, 58 procedures. Most of the patients I'm performing femtosecond keratoplasty for are keratoconics. So the minority of my grafts I'm able to use a femtosecond for, because many of them, of course, these days are endothelial keratoplasty, do a lot of keratoprostheses. And then a lot of patients who have keratoconus are not candidates because the cornea is too thin. And different surgeons will have different cutoffs. I think Roger Steiner will maybe do it for a patient whose cornea is as thin as 400 microns. But for me, my cutoff is 500 microns. And so, of course, in a keratoconic, usually inferiorly where they're the thinnest. So if the inferior mid-peripheral cornea is less than 500 microns, I don't perform a femtokeratoplasty for that patient. We're using zigzag edge profile for almost all the cases. A few other edge profiles, but I think I and most surgeons who are doing this prefer the zigzag edge profile. It really maximizes the surface area of the wound, which expedites the healing. So far, most of the cases have been a penetrating keratoplasty. Many of these patients have corneal scarring and edema, so they're not candidates for endothelial keratoplasty, but whenever we can perform a DAOK, we do. So if you're talking about a new technique, you want to mention the results. You're talking about safety and efficacy. So we'll start with safety here. We'll talk about safety as far as intraoperative complications involving the donor and the recipient. So to start with a donor, we only had one case so far with a poor quality cut. Unfortunately, it wasn't mine. It was my colleague Rex Hamilton's. Rex asked me to come to the operating room while he was in surgery to take a look at this donor that had been cut by the eye bank that he thought looked a bit oval. See a long axis this direction. And I said, yeah, it looks a little bit oval, but how can it be oval? It's a femtosecond laser cutting this donor that's mounted on an artificial anterior chamber. And the femtosecond's going to cut in a perfect circle, so I don't know how it can be oval. I told Rex it's probably just the way it was stored. I said I would go ahead and transplant it. It's not my patient, so what do I care? So he went ahead and transplanted it. This is why Rex should never take my advice. Here the patient is after surgery, 22.4 diopters of astigmatism, which for Rex is pretty good. But I think most of us would find that a little bit high. So I said, no, you know what? Let's remove some sutures. So he took out the sutures in the steep axis and got it all the way down to 11 diopters. So in this case, removed the donor cornea and replace it with another donor tissue. It's only one case, but it does show that you can have sometimes have issues with preparation of the donor, even with a femtosecond laser. As far as recipient intraoperative complications, full thickness corneal incision has occurred in 2 of the 58 cases, so 3%. And here's one of them. When you step on the laser, you should not see these bubbles. When you see those bubbles, what that means, of course, is the energy is going into the anterior chamber. You should stop immediately. Reset the depth for 70 or 100 microns less posterior. But in this case, I didn't do that. So we had a full thickness trepanation. When I took off the suction ring, chamber collapsed, and I had to suture the wound in the laser suite before transporting the patient to the operating room, which is in a different building. I was lucky that that's all I had happen. If you've got an eye that's an open eye with pressure on it with that suction ring, so you could risk an explosive choroidal. You do not want that to happen anywhere, especially in a non-sterile environment such as a laser suite. So that was one of the 2 times that's happened. Loss of suction has happened once. Here's a patient with lattice corneal dystrophy, planning to do a femto-dull. Patient, I can't blame him. He was not squeezing, normal corneal curvature. Watch this fluid meniscus over here. So I'm halfway through the treatment. I'm about to start the anterior side cut. Boom. Lost suction. So now the question is, do you feel lucky? If you do, you can put that suction ring back on and start the treatment again and hope that the cut intersects the cut you already made. But if it doesn't, if it's malaligned at all, you have non-intersecting cuts, and you're going to have to finish off that zigzag shape with your super sharp blade. And I'm not a good enough surgeon to do that. So in this case, I had to avoid the procedure. Remember I mentioned that I'm having the eye bank prepare the donor cornea. So in this case, I already had the donor cornea. It's not returnable. It was $5,000 US for that cornea, and it was not returnable. So I had to eat that because I was not able to proceed with the surgery. So it's an expensive proposition doing femtokeratoplasty at times. Poor wound closure. Here's a case, another gentleman with hexagonal keratotomy, very steep cornea, over 80 is max K preoperatively. And with the femtosecond laser we're using, the intralaser, it's a flat applanation plate. So you have a very steep cornea, which then you deform by using a flat applanation plate, and then you use the femtosecond laser. So you're distorting the contour of the cornea. And I think what happened here, this is the edge of the donor cornea. Here's the edge of the host, and this is the anterior side cut. So this should be here, but it's not. There's a big gap here. I have the radial alignment marks to confirm I did not misalign the tissue. I think there was such a distortion of the donor cornea, though, during the trepanation, just resulted in a very poor quality match. So I've now learned I really don't consider femtokeratoplasty for very, very steep corneas. If I had a femtosecond with a curved applanation plate, like the Femtech, then I might go ahead and do it. But with a flat applanation plate, I try to avoid these very steep corneas. I also avoid thin corneas. Here's a patient with macular dystrophy, which those of you from southern India see this much more commonly than I do in Los Angeles. This patient's corneal optometry may be 460 microns. This is before I had set that 500 micron barrier. Very hard time closing this wound. Even with a zigzag profile, I do not usually put in that many sutures. Very tough to close this eye, and unfortunately, if you look at the pupil, this is not a dilated pupil midriatic. This is a blown dilated pupil from high pressure day 1. So the patient ended up with Ehrens-Zavalier syndrome, partly because of the high pressure, because I have trouble closing this wound. The patient ended up with sutures out, 6.9 diopters, not so good. But in this case, the femtosecond laser saved me because I performed a femtosecond astigmatic keratotomy and got the astigmatism down to 1.8. So a good save there. As far as poor quality cut, I think the way you can avoid this is by having the eye bank do the cut. If there's a problem, just as with DSEC, it's their responsibility, not yours. Also, I have found that in areas where there's epithelial irregularity, that is often the area where I've had a poor quality cut of the donor cornea. So I often ask the eye bank to debride the epithelium if it's irregular to ensure good quality cut. As far as the recipient, to avoid full thickness corneal incisions, repeated ultrasonic pachymetry. I leave about 70 to 100 microns of the posterior cornea uncut to avoid a full thickness cut in the donor. To avoid loss of suction, I trend that not consider patients with very steep corneas to be candidates. And as far as a poor wound closure, as I mentioned before, I avoid very steep corneas and very thin corneas. Now, in the little bit of time I have left, I want to just touch on efficacy, the other part of evaluating any new technology. Looking at topographic astigmatism first. Here are the results with all of our femtokeratoplasties for all indications. The topographic astigmatism at a month, 3 months, 6 months, and then 12 months. But if we're going to evaluate this, we need to compare it to manual keratoplasty. So to compare apples to apples, I looked at my patients with keratoconus. and compare the femtokeratoplasty group, which is in red, to the manual keratoplasty group, which is in orange. You can give me just about a minute and I'll finish up. And you'll see that preoperatively, the group who had the femtokeratoplasty in it was starting off about 2.6 diopters steeper, and postoperatively about 1.3, 1.4 diopters steeper. So there's a greater flattening effect when you use the femtosecond laser, in part because the donor is not oversized. Use the same size diameter for the donor trephination as you do the recipient trephination. Topographic astigmatism, probably the most important thing to us. What is the amount of astigmatism in these two groups? We can see that there's no significant difference other than at 6 months. There's significantly less astigmatism in the femtokeratoplasty group as compared to the manual keratoplasty group. But at a year, it's exactly the same. Why do we see a difference at 6 months that goes away? It's because we start suture removal earlier in the patients having femtokeratoplasty, an average of 3.5 months after surgery, as compared to the manual keratoplasty group, where it's 5.4 months. But when you get out to a year, then the astigmatism is determined not necessarily by the means of trephination, but by the suturing. And that's why we saw no difference between those two groups. As far as visual acuity, we didn't see any difference between the two groups, no significant difference. As far as corrected distance visual acuity at 6 months out, again, femto in red, manual in yellow. But we did see a difference in, however, the amount of astigmatism required to give the patient their best corrected vision. So here we're looking at refractive cylinder at 6 months. We see a greater percentage of patients who had femtokeratoplasty who have 2 diopters or 3 diopters or less astigmatism as compared to those who had manual keratoplasty, although the difference was not statistically significant. Maybe with a greater N, it will be. So there's multiple advantages to using the femtosecond laser for keratoplasty, both penetrating as well as dull. In my hands, as I said, it really facilitates dull because it gives me a very controlled incision depth. The very deep incision minimizes emphysema of the peripheral cornea, and the wound configuration enhances matching of the donor and host surfaces. It does have disadvantages. It's more expensive. You can risk vacuum loss, full thickness incisions, and poor wound closure, as I've showed you. Also, many patients are not candidates because of anatomic features such as an overhanging bleb that make it difficult to obtain suction on this eye. And I tend to avoid doing this in patients with previous incisional corneal surgery, which I have to cross the incisions, such as patients with previous RK surgery or previous penetrating keratoplasty. So in conclusion, while the femtosecond laser offers several advantages, such as more precise incision creation, the disadvantages have really limited its use both in the United States and I think internationally as well. So I think right now it really remains to be seen whether this represents the future of incisional corneal surgery or just a passing fad. Thank you very much for your attention.
Thank you, Dr. Algavir, for that complete. You can take 1 or 2 questions now.
I'll come back. So I'll be at the end. So I can take a shot at the end.
Indications, technique, and outcome, and there are no financial interest or proprietary interests to disclose. The evolution of lamellar keratoplasty started right from keratectomy to manual to automated techniques and to femtosecond assisted lamellar keratoplasty, and the advantages of lamellar keratoplasty are that it's an extraocular procedure with no risk of endothelial rejection, less astigmatism, donor quality criteria is less stringent, and it does not preclude a future penetrating keratoplasty if required. Now, there are difficulties in manual lamellar dissection, as can be highlighted both on the donor as well as the recipient dissection. Note that the interface, despite a very clean dissection, there are irregularities which are present, and even at the microscopic level, you cannot make the dissection that smooth. Hence, the advent of the automated lamellar therapeutic keratoplasty and the microkeratome, which gives you a very smooth cut. And the advantages are that it is technically easy, less time consuming, it gives you a smooth post or a donor cut, the thickness is nearly exact, the integrity of the epithelium is maintained, and there are minimal or virtually no interface problems. The indications for ALTK in literature to begin with was keratoconus, but then these have been extended to superficial corneal dystrophies, band-shaped keratopathies, spheroidal degeneration, trichomatous keratopathy, post-trauma or healed keratitis, post-refractive surgery scars, and Salzmann-Nodular degeneration. These are some of the cases wherein we did automated lamellar therapeutic keratoplasty. The contraindications include lid abnormalities of very small palpebral aperture because the microkeratome does not go into the palpebral aperture, severe dry eye, collagen vascular disease, compromised endothelium, or field high drops. The preoperative evaluation consists of determination of the visual acuity, refraction, the slit lamp microscopy, which should document the depth and the extent of the corneal opacity, the corneal topography, the specular microscopy, and the most important, I think, is the ultrasonic pachymetry to determine the corneal thickness, because that determines what depth of microkeratome you are going to, what head of microkeratome you are going to use. So a 9-point ultrasonic pachymetry is very useful, and you know which is the thinnest part, and accordingly you will accordingly you will plan which microkeratome head to use. The microkeratome moves at a speed of 30,000 cuts per minute, has high power turbine, so that a smooth keratectomy is obtained. The heads are pre-calibrated for depths 130 to 400 microns, and it is essential that at least 2 mm donor corneal scleral rim should be there all around for engagement in the artificial chamber. Multiple suction rings are available, and generally the size of the graft that varies is from 7 to greater than 10 millimeters. Now, it is always useful to do the donor dissection first in these cases, and this is the microkeratome which is being used. A 350 microkeratome head is generally what we used for the donor, and a 250 for the recipient. And this is the translatory model that is being used. The more recent one is the rotatory model which has come, and the cap is placed back onto the corneoscleral rim, and you can use this in 2 donor corneas to do 2 surgeries. Meanwhile, the host dissection is done again using the microkeratome, and the important difference between this and the LASIK is that the LASIK microkeratome you actually don't have to move; it moves on its own. But here, the speed of the microkeratome in the Moya for keratoplasty, you have to actually guide it, and the slower you move, the thinner it is going to cut. So the donor lenticule is then fixed to the recipient bed with 10-0 monofilament nylon sutures, and notice that the interface is quite smooth after a microkeratome cut. And if you compare the interface of the ALTK with the manual lamellar keratoplasty, you can appreciate the difference very well. Now, these are some of the cases where ALTK was done: a case of keratoconus, a case of Salzmann nodular degeneration, a case of healed keratitis, and a case of healed dematous keratitis also, where ALTK was undertaken. It is also very useful for post-refractive surgery corneal haze, and this was a case where post collagen cross-linking there was a haze for which we did ALTK. We have done the ALTK at our center in over 300 eyes now, and the results are quite good. When we compared our results with the manual LK, the surgical time is less, it is technically easy, early epithelialization was seen, and when contrast sensitivity was compared, it was found to be better in cases of ALTK with early visual rehabilitation. We've also undertaken ALTK in trichomatous keratopathy, and we published this in 17 cases. 5 out of these had Salzmann nodular degeneration. The best corrected visual acuity improved at 1 year, and 70% had post-op BCVA of better than 6/18, with the median epithelialization time of 6 days. However, in these cases, because of the ocular surface problem, there was persistent epithelial defect in 6 eyes, and 1 eye had graft infection. In literature, ALTK has been compared with DLK in cases of keratoconus, and this is a study where 40 eyes were compared. The best corrected visual acuity between the 2 groups was comparable, and so was the post-op astigmatism, which was less than minus 4.5 diopters in both the groups. And the authors concluded that ALTK is as efficacious as DALK in surgical treatment of keratoconus. The sutureless ALTK has also been described, and this is a study which was done in 10 eyes, and basically you can go sutureless up to 250 microns of flap thickness. Thin layer of fibrin adhesive is applied for 5 minutes. The BCL is removed 7 to 10 days later, and in this series all corneas healed. None of them required any suturing. There was no inflammation or rejection, and the interface remained clear in all the cases. And this is a study where we used 1 cornea for 2 recipients for optimal utilization of the cornea. This we published in 12 eyes, where anterior lamellar button was used for ALTK and posterior lamellar button was used for DSEC. And this probably has a role in a country like ours, where there is paucity of good quality donor material and as such donor material, and it may help to ameliorate corneal blindness. Now this can also be combined with phacoemulsification, such as in this case. This is a corneal scar with spheroidal degeneration, where ALTK has been done first. So microkeratome is being used on the recipient cornea to fashion to dissect the recipient bed. And again, notice that the speed of the microkeratome here is quite slow, and you have to actually guide it yourself. And after this, you have to always measure the size of the recipient bed. And this is the Morea microkeratome. The corneoscleral rim is taken, corneoscleral button is taken, and is placed centrally on the Morea microkeratome. This is followed by the cap, which is then placed over it, and followed by the suction ring, which is then applied on this. The screw of the cap is tightened so as to elevate the entire corneoscleral rim upwards. And again, the microkeratome head, which is 350 microns, is being used to fashion the donor lenticule. Now, before placing this on the recipient bed, phacoemulsification is done just as one would do routinely. A little caution is required in making the moons, because now you have a little less tissue over your MVR blade as well as your main port, over your main port incision. And because some amount of corneal haze may still be present, so it is always better to stain the anterior capsule with the trypan blue dye. And phacoemulsification is then done, followed by irrigation aspiration and foldable intraocular lens implantation. And when you do these steps, always place some viscoelastic agent on the bed so that the cornea appears smooth. And this is followed by the anterior lamellar button, which had previously been fashioned, and 10-0 monofilament nylon sutures are then applied. There can be complications with ALTK, which could be intraoperative, such as a mismatch between the donor and the recipient, post-operative like epithelial healing, interface fluid, scarring, epithelial ingrowth, infection. And there are limitations because it is machine dependent. You cannot undertake it in very thin corneas because there may be perforation, and cannot do it in deeper scarring cases which have deep scars, and of course it costs a lot. This is a case which had a problem in epithelialization, and this healed finally on autologous serum. And we had two cases of infection in our series, one due to Aureobasidium pullulans keratitis, which we reported, and the other was a case of infectious crystalline keratopathy after ALTK, and was positive for herpes antigen. And when we started acyclovir, the patient responded. To conclude, ALTK is a safe and effective procedure. It offers a smooth post-graft interface. The visual outcomes are comparable to penetrating keratoplasty and DALK, and it is an expensive equipment, and there are depth-related issues which need to be sorted out. Thank you for your attention.
Thank you. The needle at about a depth of 80 to 90%, and when then inject air, and the air creates a plane of separation between the Descemet's membrane or the dual layer, and you get the big bubble. But sometimes you can get it in a single attempt, and sometimes you may require multiple attempts to achieve the same. And if your needle is placed too superficial, you get a lot of surgical emphysema. That means your entire cornea becomes white, and you are not able to, visualize what's happening at a deeper plane. Or if you go with your needle and you go too deep, your needle goes into the anterior chamber, and then when you inject the air, you find that you have a bubble that's in the anterior chamber. The success rate, even in experienced hands or with using a needle, is in the range of 65 to 70%. Simplifying the technique, what changes we have done is we first use a suction trephine, that's the Baron trephine from Catena, and using this trephine you can go down and make a cut of about 80 to 85% depth. So normally we do about 7 turns, each turn cutting about 60 microns, so 7 to 8 turns takes you about 420 to 480 microns at a trephine size of 8.5. And after you have done that, the next step that we do is we do a debulking. So we basically remove about 40% of the stromal tissue. By doing this, we ensure that the needle or the cannula can be placed much deeper. The amount of stromal tissue is debulked, so you have less chance of the stromal emphysema forming. And once the bubble is formed, when you deflate the bubble, you don't have to do this step of doing the anterior lamellar keratectomy. You can quickly deflate the bubble, and thereby you can minimize the amount of endothelial trauma because your decimus is actually rubbing on the iris once the bubble is formed. Only thing is, if you have a very advanced keratoconus and your cornea is very thin at the apex, sometimes by doing this step, you find that when you remove the anterior lamella, sometimes the apex of the cornea can have the decimus nearly exposed, and then when you try to create the bubble, the air, instead of finding its way posterior, it starts coming out anteriorly. So on an OCT, if you see that the apical part of the cornea is less than 300 microns, then maybe you will not do an anterior lamellar keratectomy. So that's the air injection cannula, which is the bottom port cannula. That's the pointed dissector with which you make a small pocket into which you put the cannula. And that's a stromal fixation forceps that helps you stabilize the peripheral edge of the corneal tissue once you make the pocket. So if we see, we have already done the anterior lamellar keratectomy. You go to the periphery, you have a small ridge. You grasp it with the stromal fixation forceps, go with your pointed dissector to the base of the cut, and then make a small pocket only for about a millimeter and a half. Put in your blunt cannula into this pocket and just wiggle it, and you will find that if you are at a right deeper plane, the movement will be quite smooth, and without too much of effort, you will be able to introduce it centrally into the cornea. And now when you inject air, you will find that you can get the bubble and in a much more controlled fashion. And because you have not done a paracentesis, the bubble cannot really expand very fast because the aqueous is kind of tamponading the bubble. So you can reasonably increase up to a diameter of about 8 millimeter, and beyond that, if you will again start feeling a lot of resistance. Just to show you the different, most of the time after a while you start getting it very consistently. And even with the femtosecond laser, you can do that. It's an expensive way of doing it, but if you have this tool, no harm, using it on your patients. So in a keratoconus patient with eczema, we have done a vertical cut and also a horizontal cut. The horizontal cut is about 300 microns, and then you can see that the anterior lamella can just be peeled off. The vertical cut goes to about 450, so you have a peripheral cut that's going for 150 microns deeper. So you go to the periphery and catch with your stromal fixation forceps, make that small pocket, introduce the cannula, and once it is in plane, you can. The rest of the steps are quite similar. The two are separate surgeries, but if you look at it, they will look like as if they look quite symmetrical. And the formation of the bubble also happens in a quite predictable manner. If you get a bubble and you're not very sure whether you've got a bubble or not, you can do the small bubble test that's been described both by Fontana and by Donald Tan. You make a paracentesis, release the aqueous, put in a small air bubble, and then the bubble remains in the periphery, and so that's a sign that tells you that you have got the formation of the big bubble. And once the bubble is deflated, this small bubble which is in the periphery comes to the center. When you deflate the bubble, use a sharp 15-degree knife with the cutting edge facing forward, and you go in the mid-periphery towards the center part of the bubble where the separation is the maximum, and you come out quickly. As you're coming out, you slice it so that you get a large opening. The other way of doing it is to put a viscoelastic on the corneal surface, and now when you go in with your knife and you deflate the bubble, the viscoelastic tamponates the air that's leaking out, and you will find that the bubble collapses very slowly. And if you have done a paracentesis before you do this step, your decimus will come back very slowly. But if you haven't done a paracentesis and you try to deflate the bubble, you will get the decimus that kind of snaps back into position, and the risk of perforation can be much higher. So once you have done that, you can remove the residual stroma that's there. If your opening is very small, you can use a spatula or the trifacet spatula, go into the space and then slice it open using a sharp knife. And once you have done that, you can use a pair of scissors to split it into 4 segments. And some people at this point of time put in cohesive viscoelastic to push the decimus back and then remove the residual stroma. But once you put viscoelastic, you cannot really see the decimus membrane, and sometimes that can be counterproductive because once your opening is enlarged, all the viscoelastic comes out, and if you cannot see your decimus, sometimes you may end up traumatizing it. So for that, if you want, you can put in some amount of trypan blue, which will stain the stromal side of the decimus membrane, and then you can put in viscoelastic so you have some visibility of the decimus at that point of time. It's important to keep the surface moist at this point of time. If the surface is very dry, the Decimus kind of drags onto your instrument, and sometimes you can perforate as a result of that. So once you have removed this stroma, you see that the Decimus has a little granular appearance. It's not a very shiny appearance, and that's what Dr. Dua has shown, that there is another layer that's present there, which is composed of about 10 to 12 microns in thickness, and it's a kind of a condensation of the posterior corneal stroma. The donor tissue punched out for keratoconus cases is usually the same size. You peel off the Decimus membrane. You can either directly peel it off, or you can use a Mercer sponge to remove that. You can even stain it with trypan blue at this point of time. And this is placed back in position. And the suturing technique can depend on your preferred suturing technique, whatever you have been using in keratoplasty. But for beginners, it's better to put interrupted sutures because you can manage astigmatism better. And in the event that even if some sutures are not placed properly, you can always replace them intraoperatively. Although this is the kind of bubble that you see most of the time, if you try to enlarge your bubble too much, you can sometimes end up the bubble rupturing once, so that's why it's important that once the bubble reaches, up to 8.5, and you feel a lot of resistance developing at that point of time, usually we stop. And at this point of time, once you have removed the stroma, if there is a little bit of residual tissue in the periphery, we just trim it down rather than trying to go below it. That's to show the different kind of bubbles that form. You can have a bubble which has a very kind of glossy appearance instead of the dense white border. And sometimes you can get a mixture of both. You can get the type 2 bubble, or you can get a combination of both. What happens when you don't get a bubble? If you don't get a bubble, or if you have a scar that's touching the Decimus membrane and you don't want to go ahead and inject the air bubble, you can do this manual technique where you have done a trephination up to 80 to 90% depth, and you can then go with a pair of blunt scissors and create a pocket 360 degree peripherally, excise it, and then use the Malbrun's peeling technique to kind of peel off the residual stroma. And you find that if you are reasonably deep enough, as you peel, the peeling process will be quite effortless, and you don't have to really do any sharp dissection at that point of time. Post-op medication, usually we use the full-strength steroids only for 4 weeks, and then the patients are kept on soft steroids like chloromethadone or Rotocred, and they continue till the time the sutures are in place. And besides that, we put them on lubricants. The antibiotic drops are for a week. Again, in most of our indication, 85% of the cases that we have done DA have been for keratoconus, and the success rate with the new instruments have been up to almost 92%. The outcome, the unaided vision has been about 618 and best corrected vision of 6.9, and the average astigmatism has been in the range of about 3.5 to 4 diopters, ranging from anywhere from 0.75 to 9 diopters. And usually the astigmatism is seen after a complete suture removal, because while suturing you do ensure the intraoperative keratometer that you get a nice round reflex, but when the healing is asymmetric or some sutures become loose much earlier and you remove them, by the time you do a complete suture removal, you realize that you end up with a lot of astigmatism. You've had microperforation in about 8% eyes, and out of that only 15 required repeat air bubble to settle the Decimus. We've done laser refractive surgery in some of the patient post-suture removal, and we've also done phakic IOL implantation. And if you don't achieve a big bubble, you find an event from cernicula. I'm sorry, you're not able to read anything on that. And then in the two groups, they have found that the final visual acuity, the best spectacle visual acuity in both the groups is similar. Although the rate of recovery when you leave behind some amount of residual stromal tissue, it takes longer for the visual recovery as compared to cases where you have had an exposure of the Decimus membrane. Newer suction refines like the Moria suction refine, which has, you can preset the depth, at 400 or 450 microns, and then when you do the suction refine, it ensures that, even if you make an extra turns, you will not enter into the anterior chamber. And the newer femtosecond laser and the intraoperative OCT, these are going to change the way you do the big bubble technique. So basically, in conclusion, DALK is a good option for patients with, ectatic corneal disorders or patients where the endothelium is healthy. And basically, for your initial cases, you should avoid any case where there is a scarring involving the Decimus membrane. The cornea is very steep, and should not try to make the bubble become very large to go beyond the edge of the trephination mark. And use of modified instrumentation does make the learning curve smoother. Thank you. Next we can go on to...
do is try not to repeat some of the points, and I'm going to try and talk about a slightly different, maybe mention some results of the techniques in our hands, and also majorly talk about femtosecond assisted laminar keratoplasty of time. So I have no financial disclosures, unfortunately. Just to summarize on what we are talking about, when we talk about superficial anti-laminar keratoplasty, that probably includes the top 200 microns of the anterior part of the stroma. Because when you go a little bit deeper than that, then it's anterior laminar keratoplasty, and then it's deep anterior laminar, and so on. So it's more to do with having less sutures in place or a suture-free technique in the case of superficial anterior laminar keratoplasty. So in the evolution of SALK, we started off with the manual technique, and then we talked about microkeratome assisted, and now we have femtosecond assisted anterior laminar keratoplasty. So what are the indications we can use it for? Anterior stromal scarring, certain dystrophies are excellent indications, and excision of plaques where the plaque is very deep and you want to tectonically stabilize it by placing a corneal tissue. So that includes a case of shield ulcer that we did, and rarely for infections, and this would be more for an acanthomoeba keratitis where there's a plaque and we replace it with a 120 or a 150 micron laminar tissue. And then as indications, as Namrata has mentioned, those includes the superficial corneal scars, including Salzmann, nodular degeneration. This forms the bulk of the indications for anterior laminar keratoplasty. So what are the techniques? We can do a simple manual dissection where you can use manual dissectors as shown by Namrata. This is very simple to do. It's low cost and it can be pretty effective in most of the cases. It can be effective as a therapeutic modality, but the limitations are that it optically doesn't give a very satisfactory result. So it's very difficult to obtain a precise and smooth interface when you do a manual laminar dissection. And the resulting interface irregularity in haze leads to a suboptimal visual outcome. And you cannot, it's not reproducible, you're not very sure what were the dimensions of the donor and the recipient corneas that you took. And in certain instances where you think that the scarring is anterior, but as you dissect the host, you can sometimes have a perforation and you need to convert to a full thickness technique. So manual dissection is good in the way that it's very simple, but then it's not extremely optimal in my perspective. The second technique that was very beautifully covered by Namrata was a microkeratome assisted anterior laminar keratoplasty. So I won't go through most of the techniques. Just to say that the advantage, of course, you have an extremely smooth dissection and therefore you have better visual outcomes. But you do have disadvantage of, just like in LASIK, you have when you're creating the flap, you don't really know what you're going to come out with. So there's unpredictable flap thickness in certain instances, and you can have complications of the flap. So we designed the study that I was going to present about our cases is pretty similar to the technique described by Patel et al., and in which they had 9 eyes of 8 patients who they followed up for 2 years. And based on this, we had selected cases where we had 21 eyes of 18 patients, and majority of these patients' indications were post-stroke trachomatic corneal scarring, and there were 4 cases where we had Salzmann nodular degeneration, and 3 patients with spheroidal degeneration. Although we had many more eyes which underwent ALTK, but we didn't include them in analysis because they had less than 1 year follow-up or they were lost to follow-up. So these cases with at least 1 year follow-up sort of went through at least cohort of, they're not consecutive cases, so they were operated by multiple surgeons. Initially, we had the HP microkeratome which we used for patients for the recipient cornea, and then when we got the Moria system, we used the Moria for the donor cornea, and we had the XP or the Moria for the recipient cornea. So the results in our hands was that we had reasonably good outcomes. We had 20, 60 or better in most of the patients, about 80% of our cohort. But the main problem that we saw with our cases was that the mean postoperative astigmatism was very high. So although the mean was 4.5, the range was as high as up to 14 chapters of astigmatism. The good part was that we didn't really have any intraoperative complications in any of our cases, but almost 7 of these 21 patients had interface haze, which contributed to the not very satisfactory color visual acuity in 7 of them. And in the subgroups, we saw that 2 patients had recurrence of the primary disease, which was corneal scar in the post-trachoma group, and one of the Salzmann nodular degeneration recurred with the degeneration once again. So with that, I would like to discuss another technique, which is femtosecond laser-assisted, femtosecond-assisted lamellar keratoplasty, or FAL. So as Dr. Alavi had highlighted, so the advantages of this technique is it's highly reproducible fit between the donor and the recipient. In fact, the best fit that you can get. There's no limit in what kind of shape you would like to create, as you mentioned, and in the curvatures that you would like to obtain. And then you have an extremely favorable wound healing response, so you can do this as a sutureless technique. So the early results were published by the group at Bascom Palmer, and they had pretty encouraging results of the cases with excellent outcomes in most of the patients. So this series mentions the largest number, in which they had 13 eyes, and the mean best correct visual acuity was as good as 20/40 in just a month's time post-operative, and this visual acuity was more than 20/30 in half of the group at 1 year. They did have surface haze, and there was recurrence of granular dystrophy in one eye each. And what they did was several adjunctive procedures in order to improve the visual acuity. So this best corrected visual acuity was without any adjunctive procedure. And when they did either PRK or PTK, and they had a few other complications like epithelial ingrowth, they could improve the visual acuity to 80% or better in the entire cohort at the end of 1 year. So this is pretty encouraging visual results in the case of FAL, or femtosecond laser-assisted sutureless anterior lamellar keratoplasty. So the machine that we have access to is the Visumax femtosecond laser system, which is an excellent system, but it doesn't give you any side profile. It's a straight-on side profile. And I'd like to just discuss a few cases under this, using this technique. So we had this very interesting family where we had a father, daughter, and son with Rees-Buckler's dystrophy, or the anterior-most variant of granular dystrophy. It was a non-consanguineous parents, and the father, as well as the daughter and son, were affected. All of them had undergone multiple procedures. Most of the procedures were done with us. So to show you how the donor and the recipient surgery is done in the case of FAL, you can decide the thickness of the lenticule you want for the donor. So since you want it to be sutureless, we pre-decide what is the amount of stroma that we want from the lenticule. So this is showing the lenticule cut, which should be about 120 to 150 microns. It would be slightly more than what we would dissect for the patient. The reason being that the stored tissues will be edematous. So what you can see is actually the centration, which is not centered to where the suction was applied. And I'll come to that, why that happened. And this is in the recipient. So there are some bridges or some adhesions because the recipient cornea is not very clear, but it's easy enough to dissect that cornea, and you can just place this thin sliver of corneal tissue and just put it down in place, pat it dry, and you don't need glue or sutures. Bandage contact lens is applied, and you wait for 5 minutes, and then this is done. So the technique is extremely simple and very reproducible. So discussing those three cases, the father is a 73-year-old at the time when we did FAL for him. And in both eyes, he'd undergone PK, he'd undergone cataract surgery, and he'd undergone PTK twice in one eye, thrice in the other eye. And his visual acuities when he presented was 2200 in the right eye and 2080 in the left eye. So we did FAL for his right eye, and this is a preoperative photograph. Post-operatively, at the end of 3 weeks, although you can see many residual opacities, but you know that these patients can see reasonably well in spite of these opacities. His visual acuity improved to 20/60. At the end of 6 months, his visual acuity improved to 20/40, and he's still maintaining that visual acuity even now. The daughter, she's 43 years old. She had undergone PK in the right eye 20 years ago and left eye as well. She had undergone PTK twice in the right eye and once in the left eye. And her entry-level visual acuities were 20/60 in the right eye and 21/25. She had in fact come in for a PTK for her left eye. So we did FAL for this daughter. And the visual acuity, the result is extremely satisfying. The visual acuity improved to 20/40 within a week's time, and she's maintained the visual acuity at the end of 1 year of follow-up. So this is 11 months follow-up, showing that this is 20/50 unaided. With best corrected, she has excellent visual acuity. The son is 37-year-old. He's undergone PK in both eyes and PTK in one eye. So we did FAL for the worst of the two eyes, and the patient has good visual acuity. A few other interesting cases that we have 7 eyes so far, and most of the surgeries are done by my colleague Mukesh Taneja, and some of them are done by me. So we looked at the results of these cases, and we saw that we had, in the follow-up of 6 to 24 months, we had extremely gratifying results of unaided visual acuities of 20/60 or better. So this is one case where there's a corneal scar due to a foreign body. In fact, there was a glass particle which was lodged into the corneal stroma. So we did FALC, and we were very we had a lot of trepidation whether the gas would go below the foreign body or not, the glass foreign body or not. So it did, and we could just remove the corneal tissue, including the glass foreign body, and put into place a donor lenticule of 150 microns. So this patient is doing extremely well. This was a patient with advanced sphenoidal degeneration as well as total cataract, and we did FALC for this patient, followed by cataract surgery in his 20/20 visual acuity. Notice his cornea, which was so bumpy preoperatively, and this is post-operative. You can barely see the interface in this case, and it's an extremely smooth, excellent topography for this patient. In fact, he has no refractive error post-operatively. So we did have a couple of complications. It's very difficult for the patient to center. That's the major difficulty that we face, because the patients have poor visual acuity, they can't fix very well, and even if you mark what is the center, by the time you apply the suction, they're looking somewhere else. That has been one difficulty. And in one patient on the first post-operative day, we had sort of displacement of the graft, but then we, just like how you put your LASIK flap in place, we did the same thing. We didn't suture it, and then this patient is doing pretty well since then. So I think that between the techniques that we have now and having done all of the techniques, I would definitely prefer SALC. Of course, it's expensive. You should have a femtosecond machine with you, but then the outcomes are extremely gratifying because the surgical precision is excellent. Thank you very much, and thanks to Dr. Fogler.
So we are moving backwards, so now we finally come to Rishi's presentation on manual techniques of anterior lamellar keratoplasty.
Okay, so I'm sorry I had to do this last, but my file got corrupted and I had to redo the whole presentation while I was sitting. So I'll be talking about my manual techniques of deep lamellar keratoplasty. The reason that there are so many techniques for deep lamellar keratoplasty is because it's a difficult surgery, and that's why we're having a complete session on it. These are all the various techniques which are popular. Of course, the big bubble technique is the most popular because it gives very nice bearing of the desmoid membrane, and you get almost no interface irregularities, and visual outcome and optical results are very good. But it has its problems. You sometimes end up having a full thickness perforation into the anterior chamber. You can end up having a lot of corneal emphysema and may not get a bubble in spite of multiple attempts. So, and there's a huge learning curve. While removing the stroma, again, you might end up rupturing the desmoid membrane if you're not careful. There are other techniques through which deep lamellar keratoplasty has evolved. The most common manual technique is the direct open dissection technique, or the cut and peel technique, in which you just take out layer by layer using some sort of a lamellar dissector, and you do 3 or 4 times the same removal of one by one layer. The problem in this is once you reach a very deep plane, you really don't know when the desmoid is going to touch your blade or the sector, and it's very easy to have a perforation if you're trying to bear the desmoid. If you're trying to leave it pre-desmotic and you're okay with leaving behind a little bit of stroma, you can often do the procedure quite safely, but then your visual outcome will not be as good as a desmotic graft. Air insufflation involves injection of air basically to separate the stroma from the Duas layer of the desmoid membrane. Hydrodelamination, you are basically opacifying the stroma by, air insufflation is not that, that's the bubble. Air insufflation, you are pacifying the stroma with air. You are creating an emphysema, and that way you are able to see the stroma all the way till its depth. Okay, and the same thing when you put fluid, that's called hydrodelamination. Viscodissection is a technique in which one introduces viscoelastic in a deep kind of an interface which is dissected with the blade. This technique was described by Melis. Finally, you've got the automated systems like the ALTK and the FALC, which have already been described. The big bubble technique has already been discussed, so I'm not going to go into that. It has its advantages and its problems. I'm going to stick to the manual techniques. The manual techniques, basically the popular ones are the cut and peel. Again, my videos are not playing, I'm sorry. Can I just, 1 second.
construction, and in the eye it refers to the maintenance of ocular integrity. And we can do this either by tissue addition or by replacement, and this serves to protect the structural and functional integrity of the cornea. There are various adjuncts and tools that we can use when you're doing tectonic surgery on the cornea, and this includes amniotic membrane use, cyanoacrylate glue, and obviously lamellar and penetrating corneal grafts. When you're operating in the context of an eye with a deranged limbus or a dry eye, sometimes after tectonic surgery you can have a persistent epithelial defect, and in this context amniotic transplants and autoserum tears can help you. I'm sure we've heard these talks before in other sessions. If you have a limbal deficiency in association with your tectonic surgery, then a limbal transplant will often help you reconstruct the cornea. If you have stromal ulceration because of excessive collagenolisis with a risk of perforation and associated infections, we can use cyanoacrylate glue to help because this seals the stromal surface. It stops neutrophils from accessing the melting stroma and buys us time for both stromal healing and epithelialization. The technique of cyanoacrylate glue is quite simple. Don't need to be a corneal surgeon to do it. This is an eye with a rheumatoid corneal melt and a decimeter seal. You could do this on a slit lamp if you like, but it's obviously more comfortable for both the surgeon and the patient with the patient lying down under the microscope. The glue does not stick over intact epithelium, and therefore you first have to peel the epithelium over the area of the melted stroma, and you could just use a fine tip forceps for this. And once you've got all of the epithelium off in the area of interest, which is basically the melted stroma, and expose that area completely, we then can dry that area thoroughly because the glue tends to polymerize in contact with any liquids, and then you can get the glue in a 1 ml syringe with a 30 gauge needle. And if you can get the patient to stop moving his eye for just a second, you could use that little drop on the tip of your needle to paint it into place over the entire area that's ulcerated. And just take care to have a nice thin film. You don't want to have mountains and valleys because then placing the BCL becomes a little difficult. The glue polymerizes in about 30 to 40 seconds. You just wait till you get a nice thin film over the area of weakness. And once you've done this, you can put a BCL on to protect the undersurface of the upper lid from the rough glue. And this is basically the procedure, and this will buy you time until the underlying stroma can heal with the steroids and the other things that you're going to use for the patient. Sometimes you may have a filtering cicatrix, or you may have a larger perforation which is 2 millimeters or thereabouts where the glue really can't help, and there you can use a small patch of corneal tissue as on the bottom left to seal that area. And this is lamellar surgery. It's deep lamellar surgery, so it fits into our definition of what we're talking about. You could use corneoscleral tissue, and this results in shape restoration, and the function is preserved because we are operating on the periphery without going and impacting on the visual center. The principles of such surgery would include an assessment of the perforation itself, looking for whether there is infection or not. You need to plan your anesthesia and the actual surgical approach, the tissue that you're going to use for replacement, and all of this will help you offer a prognosis to the patient. You start by marking the visual axis because we want to try and avoid violating that. We mark using various trifines the outlines of the surgical process that we are going to proceed with, and these are small dermatological punch trifines to give you marks at the edges. You can use a sharp knife, any kind, as 15 degrees fine, to make vertical walls along the outlines you've marked. And then you get into a deep plane of about 80 to 90%, and you can excise that area of diseased tissue with either a 15 blade or just a simple vannas, which is a more surgical trace. Leave the iris excision for the last because you want to avoid perforating or losing the anterior chamber. So once you've created your bed, you can make your measurements, and then you can sew your corneoscleral rim onto an acrylic ball implant to use an artificial anterior chamber. And then if you want to match the depth of dissection on this with the depth that you've created in the recipient eye, it's about 80 to 90%, you can shave off a layer of tissue trying to maintain the plane of dissection. We've already got the dimensions of the graft marked on this tissue as well, and you can cut it out. The whole idea of using trifines is to give you matched margins, so at least it helps you initiate the surgical process, the two edges that match well. You can put in a few cardinal sutures to keep the rest of the graft in place, and you can then tailor the graft into place, and that's relatively simple because you have your marks, and you do all this with some air in the anterior chamber to give you a shape to the cornea. Otherwise your graft will end up being too flat on the cornea. You finally bury the knots, and that's basically the principles of the procedure. And I'll show you another example of the same thing without all these little slips. Basically, you need a paracentesis. You need to get in air. This was a small perforation, but it would not seal with glue. We tried once and it came away. It's right in the periphery, so we're going to have to pass some sutures out at the limbus, and therefore it's always nice to do a peritomy there. Smooth that area out, and then again we're using trepines. Any handled trepine is fine. Here it's about 9.5, I think. You can use the same trepine, if you will, for the inner curve as well. And the idea is to get curved outlines so that you can then match them more precisely, although you could, I guess, do it with freehand cuts as well. It will become much harder to match the tissues there. So this is the curve on the outside of the mark made by a dermatological trepine, and you want to go right and deep, get the plane of dissection here, get about 90% ideally, because you don't want your graft to stick up outside its bed, and that's one of the most common reasons why these procedures don't work. You don't get a smooth surface on the anterior part. So the dissection of this tissue can be done with a scissor, you can do it with a knife, with a crescent, it doesn't really matter. You just need to get deep and get rid of it. And once you've done that, you can then go back to the donor to fashion that as well. Here we're basically using full thickness donor tissue because you've gone right and deep about 90% on the recipient bed. Just trying to make a mark to tell me how much of donor tissue I will need. And once you've got that, you can basically cut along those marks to fashion the tissue in some way. You'll of course be fine-tuning it on the recipient eye. And here, because it's full thickness tissue, the DM can be peeled off. The patient has his own DM in the area of surgery. And the same process then ensues. You just use one of the matched margins to get your graft in. And basically there's some science to this, but you have to make it up as you go along. And in each case it's slightly different. So it's not like a completely refined cut wound where everything is matched perfectly as with the femtoseconds. So you can use this in a variety of situations, the same basic principles. The photographs are showing up much darker than on my computer, I'm sorry. This is a Murins with advanced melting, and basically you can use these kind of crescentic banana-shaped grafts. Atherians, which is extensive, and inferiorly there was just DM sitting there. And again you can do these kind of inferior crescentic grafts. You can also do them in situations where there's infections, as in this person who's post-pterygium surgery, referred with a deep infection which is fungal. The same principles again, although here you can use a trepine to give you a nice circular mark, 6 millimeters, or you make those vertical walls with a knife. If you have a diamond knife, that will be easier, but you can use a metal blade as well. And once you've got the correct plane, you can do this multiple times, of course, as well. Here the idea was to avoid penetrating into the anterior chamber because this was a fungal infection in the periphery, and you just keep going deep until you get well underneath the infected part, and then you go out into the sclera as well, where you can create a nice 6 millimeter bed. And once you've got that done, you can use any piece of cornea that you have with you, peel off the DM, put it in, and put in sutures 12 of them if you like, just like a PK, and bring the vascular conj over it, and that will be the end of the procedure. So this is the corneal tissue going in, and you sew it just like everybody else. And this is how it looks post-operatively, and this is another example of another patient with a worse situation, and this is the outcome at the end of surgery, and you can preserve the visual axis. So this is mostly manual, but sometimes with tectonic surgeries, as in these persons, a person with extensive TMD-related corneal thinning, which is quite peripheral, you can use a big bubble as well to do the dark, and this is both tectonic and optical. And similarly, if you have a severe fungal infection, which is fortunately only in the stroma at this point, but going from limbus to limbus, you can use the big bubble to do a tectonic and therapeutic procedure. So basically then, I think the basic principles of tectonic dark are very, very important, because here it's freehand and you're having to rely on your skills a little bit more because it's not femto-driven. And it allows you to preserve the corneal visual axis. You can use adjuncts like glue and amniotic membrane. And while the big bubble is sometimes helpful, the main focus of these techniques will be your manual approaches. I'd like to invite you all to the Keracon 2014, the second meeting of the Cornea Society. It will be in Chennai, my city, and it's in December, and you're all welcome. Thank you very much.
Very good when you get a bubble, but you don't always get it. And even if you do get it, removing the stroma can be tricky. You can end up with perforations if you don't handle the tissue carefully. Now, the conventional technique of manual deep lamellar keratoplasty involves removing layer by layer of the stroma, and usually you end up using a sharp or a semi-sharp instrument like this, and When you're doing that, you don't know when you're going to touch the desmoid membrane with that, and sometimes you can end up perforating the desmoid membrane if you're too aggressive. So doing a pre-desmotic valve is okay, but if you're trying to do a desmotic valve in these cases, we can end up in a situation like this, and this can happen in any part of the cornea. It could happen in the periphery, it could happen in the center, because you're using an instrument to do the dissection. So we have modified that particular procedure, and what I routinely do for my patients when I'm doing a dial is this manual technique of groove and peel, especially when I don't want to do a big bubble. This is my preferred technique of choice, and it works very well in my hands. So what we do is we do a partial thickness definition, as you can see in this particular case. The pointer is working. And once you've done that, you basically do a blunt dissection using a scissor all around underneath your definition mark. So you make one complete round, then you go in a deeper plane. So you keep going peripherally and dissecting with a scissor like this. The advantage of using this is a universal cornea scissor. This is a blunt tipped instrument, so it's quite safe, and you don't cut till you actually see that you have separated that plane. And because the curvature of the scissors pointing anteriorly, you don't really rupture the desmoid membrane very easily. And the advantage is because your dissection is entirely in the periphery of the cornea, even if you do have a perforation, you can manage it very well. And it's very, very rare to have a perforation at this stage. So the entire dissection happens only in the periphery. You're going, making 2 or 3 rounds and going spiraling deeper and deeper with each pass. And at some point in time, you start seeing the desmoid membrane or the duas or whatever you may call it. It looks like a glassy membrane, and it's very easy to identify once you've seen it. So in this particular video, you can see in this area the desmoid membrane has been exposed. It's a good idea to expose at least 2-3 clock hours before you start peeling. So once you've exposed 2-3 clock hours, all you need to do is grasp the central annular tissue, and it just peels off. Even the areas where you're not really exposed the desmoid, the tissue separates in that plane, and completely you can remove it off. Sometimes you will have some fibrillar attachments, but they don't really matter either optically or visually, and you get very good results right on the first postoperative day. So, and the advantage of this is there's no instrumentation in the central part of the cornea. The central part of the cornea, the section is done purely by stretch forces which are distributed over a large surface area. So it becomes very safe. And you don't really have to rip it off in a hurry, do it slowly. And you can see these small attachments between the stroma and the desmoid membrane, so sometimes they break in the middle, they can break close to the desmoid membrane, but they're so fine, they don't really matter. It's a good idea to give some counter traction sometimes, because that helps, otherwise the whole globe gets pulled to one side while you're doing this. So you see even the area where I didn't really separate the desmoid from the stroma, you can pull it off, and it comes up quite well. I've done hundreds of cases like this, and the results are wonderful. And very, very rare that you end up with a perforation unless there's been an old hydrops or something on these cases. Rest of the steps are similar to any dial. You just take a stromal button and put it there and suture it by whatever technique you're comfortable with. So that's the technique of lamellar keratoplasty that I follow, and you can see as early as the first day you get very good clear compact corneas. So this is another patient with the keratoglobus in which I was trying the same technique, and you can see the cornea is very thin, so just being very tentative in the dissection. It's almost epithelium thickness and just a little bit of stroma. To my surprise, in these cases, the stroma is not really adherent to the desmoid membrane much, and once you have really created a plane of separation, you don't need to dissect anymore. You can just lift it like a LASIK flap, and the entire stroma just peels off. See that? There's no dissection being done on this side, but you can just lift it off. So even though you're not on you have not really dissected, you can, if you find the right plane, the whole stroma can be taken off. So particularly in keratoglobus, I think this is a fantastic technique, because if you're trying to get a big bubble, you might, first of all, the big bubble will not extend to the periphery of the cornea, and you might end up perforating the cornea. And the last thing you want to do in the keratoglobus is have a full thickness transplant, because, as you know, this would be very likely to reject. I've also done this technique for, so that's, ignore the video on the left, that's just a big bubble. So for acanthamoeba keratitis, we've done quite a few dials. And you see how nicely it comes up. Again, infectious keratitis, for some reason, maybe because the stroma is edematous, it peels off very nicely. You just need to go close to the plane and just hold it, and you can just rip the whole thing off, even in areas where you have not dissected. So this This is just one of those patients, and you can see that the cornea clears up quite well after DALC. Air insufflation is again one of the older techniques described by Aquila. So basically, I don't really use this technique, but when I'm trying to do a big bubble, if I end up with a large emphysema, I just start peeling the layers one by one. You can use it either using the cut and peel technique or the groove and peel technique. The advantage of opacifying the stroma with air is that you can see the stroma all the way to the descemes membrane. So even if you're removing layer by layer, you can be quite sure that what you're cutting is stroma. And once you stop seeing the opacification, then you just be a little careful because you're likely to be close to the descemes membrane. Similarly, one can also use fluid, and this was a video from Sugita in which is using fluid to hydrate the stroma, and then again you remove layer by layer or whatever technique you may use to excise the stroma, basically opacifying the stroma and thickening it with fluid so it becomes a little safer to dissect. Meili's technique is also a very nice technique of pre-desmetic DALC. So if you are not really worried about going all the way to the descemes, do a deep lamellar dissection like you do in DSEC, in the manual DSEC, using any one of lamellar dissectors. This is usually about 400-450 microns, and go all the way to the opposite limbus, put some viscoelastic in the interface, and then refine from the front and put in a new stromal bud. You can also combine DALC with surface procedures like conjunctival limbal peel transplantation. This particular patient had severe unilateral chemical injury with some keratinization, dense symblephera. So they released the symblephera. Once you removed everything, you saw that the underlying cornea was very opaque and thinned out. I wanted to visually rehabilitate this child because I didn't want to become amblyopic. So on table we decided to also do a lamellar procedure. I didn't want to go all the way down to the descemes, so just did a manual dissection. Just used a narradiodialysis spatula to just do the dissection safely, and put a large hand-fashioned graft along with the planned stem cell transplant procedure. And it's important that you remove the epithelium from the graft because you're going to anyway put amniotic membrane with epithelial transplant. And you can see that this patient developed a very good, nice, clear cornea with wonderful improvement in the vision. So it's not that every technique is perfect. If you're doing this kind of a technique in an old hydrops and you're trying to be close to the descemes, that's going to happen. But that doesn't mean that you have to convert to a penetrating keratoplasty. You can do one of many things. You can put in an air bubble and complete the surgery from the periphery to the center. You can put a small patch of stroma there, even fix it with fibrin glue if you like, and then after you put the stromal button, you can go back with a blunt tipped instrument and pull out that little patch quite safely. Of course, you should make sure there's some air in the anterior chamber. And you can see you can just grasp that little island of stroma and pull it out, and next day you can have a clear cornea like this. To conclude, DALC is the gold standard. Although big bubble is preferable, a variety of manual techniques are available. You can use a combination of several techniques, whatever works well in your hand. The principle that you should follow is try to do minimal instrumentation and don't always try to chase a descemetic dissection. It's alright to leave behind a little bit of stroma. Sometimes you do get a little bit of interface scarring, but usually with corneal remodeling, this interface scarring does go away after a few months. So in the long run, most of these patients do get good results, and you can be quite satisfied with DALC. Another important thing I'd say is if you have a complication, don't be in a hurry to convert to penetrating keratoplasty. You can salvage most perforations. Thank you.
Keratoplasty, and sometimes you have to use a combination of those. Now, looking at whether anterior lamellar keratoplasty has a role in ocular surface reconstruction, yes, Rishi showed you one of his patients, and often we see these kind of patients often in young children and after chemical injury or thermal burns, and they come back with this kind of a clinical picture. And although we do surface reconstruction procedures and we do limbal stem cell transplants, sometimes you require to do a corneal replacement procedure to optically clear the cornea and for visual rehabilitation. The thing is that the timing of surgery, whether you need to do it at the primary procedure when you are doing the limbal stem cell reconstruction, whether you need a corneal replacement procedure at that time, or whether you would wait for the surface to recover and then do a corneal replacement surgery at a later date. And the technique, whether you do a penetrating keratoplasty or you do a deep anterior lamellar keratoplasty. Now, Rishi showed you some of the techniques, and this is one of the surgery where, in chemical injury, again, because the anatomical landmarks are not properly defined, often sometimes you would use something like a manual technique where you go layer by layer, and as you reach the deeper layer, you can realize that this is quite a depth because you are able to peel off the cornea, and that's the end point, so you shouldn't attempt to go deeper than that. Sometimes you may have some microperforations, which can easily be managed by putting an air bubble in the anterior chamber. And here, this was a unilateral injury. We took a conjunctival limbal autograft from the fellow eye with amniotic membrane, and that's the kind of outcome that you can see in these kind of cases when you do with anterior lamellar keratoplasty. This is another patient with thermal injury. This is a patient, unilateral chemical injury. We did a anterior lamellar keratoplasty with conjunctival limbal autograft, and you can see that the post-operative outcomes are quite good. You can do it using a single graft, or you can do it by the SLED technique, or you can even do it by ex vivo culture of the limbal stem cell biopsy that you take from the fellow eye. This was another patient with this kind of chemical injury, multiple surgery, and then we did a anterior lamellar keratoplasty, did well. We did publish a paper back in 2005 where we looked at the combined surgery, doing a deep anterior lamellar keratoplasty along with conjunctival limbal autograft and amniotic membrane transplantation in unilateral severe chemical injury, although a small series of 7 eyes of 7 patients. The results were quite favorable, and with a follow-up of almost 2 years, the outcome was quite good, and the surface was stable, and the average best corrected visual acuity was about 20/50. There was another paper from Japan where they looked at limbal allograft along with deep anterior lamellar keratoplasty, and these were patients with bilateral limbal stem cell deficiency, included conditions like Stevens-Johnson syndrome, aniridia, and even in these eyes, the DALK was performed using the viscodissection technique and using a 360-degree keratolimbal allograft, and with immunosuppression, follow-up of same about 18 months. All the eyes did pretty well along with systemic immunosuppression, except for one eye with Stevens-Johnson that had persistent epithelial defect. So a DALK, when you do a combined surgery at the same step, seems to work very well. However, a penetrating keratoplasty in this situation may not be very favorable because, number one, that the bed is very vascular. You have a lot of surgery that happens on the surface. The surface healing may take longer. And at the same time, the risk of rejection would be higher. And it becomes an intraocular procedure, whereas when you do a DALK, it's more of an extraocular procedure. If you look at some of the papers that I've looked at, the outcome of doing a surface reconstruction with or without penetrating keratoplasty, either at the primary surgery or doing it later, in this they have found that when you combine with penetrating keratoplasty, the limbal stem cell graft does not survive very well as compared to doing a limbal transplant first followed by a penetrating keratoplasty later. So they did not recommend doing a penetrating keratoplasty earlier, and this paper from LVP by Dr. Sangwan also looked at when you do autologous limbal cultivated stem cell transplantation, if you combine it with a primary keratoplasty or if you do a keratoplasty 2 months later, they found that the recurrence of limbal stem cell deficiency was much higher when you combine the penetrating keratoplasty with the primary surgery. So this has been the difference between penetrating and DALK. With DALK, maybe yes, you can do the surgery, they kind of said the graft survives better, the surface is okay because you don't manipulate much. Whereas with penetrating keratoplasty, because it's an intraocular procedure, maybe the immunological reaction and that is enhanced, and that could be the reason why the surface doesn't, survive better. So, if you were to face with this problem, sometimes DALK seems to be the procedure of choice to manage corneal opacity in patients with ocular surface disease. In the primary procedure, or if you feel that the surgery is too extensive and you want to first stabilize the surface and do the corneal procedure as a second stage, even that can be attempted. So this is short about the role of anterior lamellar keratoplasty in surface reconstruction. I think we are on time. We have exceeded about 5 minutes, but there are no sessions after this. So we still have few of our speakers still here. I see Dr. Aldabay has already left. I don't know whether Dr. Srinivas Rao is still here. But if there are any questions, 1 or 2 questions, we will be willing to take. I think everything was very clear, so nobody has any doubts. So I thank all my speakers for their participation, and thank you all for a patient hearing.